Good afternoon and welcome to Chapter 27, Toxicology. Lots of stuff to talk about in toxicology. Be sure that you have logged in in order to get credit for this particular lecture. So let's get started. All right, so as an introduction, toxicological emergencies require that you think very critically to identify the substances that are involved, determine your differential diagnosis based on recent treatment guidelines, and then also formulate your treatment based on anticipated clinical course of your patient. It is the cornerstones of pre-hospital emergency medicine. So therefore, a solid understanding of various substances and medications is required, and also a solid understanding of pharmacokinetics. So, some of the terms: toxicology, it is the study of toxic or poisonous substance. Pharmacokinetics is the activity of the drug in the body over time, including processes of absorption, distribution, and elimination. Drug, it is a substance that has some therapeutic effect when given in the appropriate circumstances and in the appropriate dose. Poison, it's a substance that could damage structures, whose chemical action could damage structures or impair the function when introduced into the body. Even a small amount of poison may cause serious symptoms and even possible death. Toxin, it is a poison or harmful substance that's produced by bacteria, animals, or plants. Licit, it is illegal. Illicit, it is illegal. So then obviously an overdose is the outcome of taking drugs in excess. All right, so bioavailability, the term is the percentage of unchanged substance that is present in systemic circulation. And then the half-life is the amount of time that's needed for an average person to metabolize or eliminate at least 50% of the substance in the plasma. Excretion, that is the removal of a drug from the body. An antidote is something that counteracts the effects of poison. All right, so types of toxicological emergencies. Toxicological emergencies usually fall under one of two categories: intentional suicide, intentional, which would include suicide and criminal activities. Also date rape drugs such as rohypnol, also in chemical warfare, and then also unintentional, which is more common, can occur in many ways, including neglect, oversight, idiosyncratic reaction, confusion about one's drug regimen, the patient's medications, period. They need to pay particular attention to any new medications or changes to the dosage. So make sure that the patient isn't taking multiple smaller drugs from different prescribers. Consider over-the-counter or OTC medications, home remedies, and herbal supplements. This is very common in children. It may also occur in the workplace as well. As you can see, this little girl here, she's obviously got into a bottle of pills, and she's looking at them. Unfortunately, sometimes the folks that put their medications away don't utilize the childproof portion of it. And besides that, what is childproof? My son, when he was little, could get into anything. I'm sure there's many folks out there hearing my lecture that can relate to that. All right, so poison control centers. Poison control centers can provide a specific rundown on a lot of different information. The telephone number is 1-800-222-1222. It can provide a rundown on poison ingestion, a poison's toxic potential, and the steps to negate the effects of poison. There's also electronic resources. There's mobile device apps such as Hippocrates that can assist with pill identification. Also, the National Capital Poison Center has an online tool and a mobile device app called Web Poison Control that can be used by lay people or healthcare providers. Specifically, a collection of data on poisonings in your region from your call is very, very helpful to show trends, also show developing public health problems, and current treatment protocols. Routes of entry for poisons. Obviously, you can get poisoned by ingestion, which may produce an immediate damage or delay effects. Caustic substances especially cause immediate damage. And then some poisons must be absorbed into the bloodstream before they can really cause any damage. So some considerations, all possibilities regarding the substance, whether the ingestion was intentional or unintentional. Most common sources include the following: medications around the home, household chemicals, assessment clues. They may include, stained fingers, lips, or tongues, sudden onset of stomach cramps with or without nausea, vomiting, and diarrhea. Prescription and over-the-counter pill bottles. Consider the dates on the labels and the quantity remaining. Also, the amount of time a substance remains in the stomach depends on the person. Management aims to remove or to neutralize the poison before it gains access to the intestine. Forced vomiting is not used, but activated charcoal may be used. Gastric decontamination may occur at the hospital as well. All right, so poisoning by inhalation. It's a toxic agent that's maybe present in the environment, may be unintentional or intentional. Specifically, responders need to be very, very careful with this. It may occur when the toxic agent is present when you arrive on the call. So you need to make sure that you're protecting yourself with something such as a self-contained breathing apparatus. All right, so make sure that consider the possibility of inhalation poison even if it's not mentioned in the dispatch. Chemical suicide or detergent suicide involves mixing household chemicals in an enclosed space. Toxic gases are created. The gases may be colorless and odorless. They may place responders at risk of serious injury. So maintain your situational awareness for warnings for a warning note from the suicidal person or other indications of this hazard. Inhaled toxins usually reach the alveoli very, very quickly, providing almost instant access to the circulation. The window of opportunity for problem identification and treatment is very, very limited. So first consideration obviously is scene safety. Don on the proper breathing apparatus, so get those people responsible that have those breathing apparatuses to go and remove the patient from the environment. Move the patient to a safe environment before evaluation and treatment. There's a wide range of signs and symptoms depending on the toxin. Look for the information at the scene to help to identify the toxin. In a residential setting, ask appropriate questions. In an industrial environment, ask for safety material data sheets. Use the wireless information system for emergency responders called WISER. That's WISER. You get a lot of information on that, on any industrial type of chemical, and get the MSDS sheets on them. Ask it also about potential hazard substances, and use the Poison Control Center and medical control as needed. Also, you need to correct hypoxia. Therefore, you're delivering high concentrations of oxygen and maintaining adequate ventilation. Also perform pulse oximetry and capnography. All right, by injection. Usually this particular type of issue is the result of a sting or a bite from insects and animals. It varies by geographic location. Snake bites and scorpion stings are prevalent in the southwestern United States. Jellyfish, Portuguese man-o-war, and sea urchins and sea anemones stings are very prevalent in our coastal areas. Wasp, yellow jackets, and hornet stings are common throughout all over the United States. All right, so poisons from these little boogers, some injected poisons are neurotoxics, and others, poisons produce localized or systemic reactions. Physical findings will provide the clues. This is especially true of local reactions. Signs and symptoms can vary greatly. Also, then we move into the abuse of intravenously administered drugs. This definitely may cause a prompt call for EMS. Drugs include heroin, cocaine, amphetamines, a speedball, which is a mixture of heroin and cocaine together. All right, so poisoning by absorption, it has a longer time of onset. Usually it's a pesticide, and often they are the most serious. Scene safety is paramount with these types of patients. Decontamination and the involvement of the hazmat team may be required. Remember the old saying, the solution to pollution is dilution. So need to get this stuff off of as quickly as possible. All right, so understanding and using toxidromes. Many drugs result in similar signs and symptoms. Syndrome-like symptoms of a class or group of similar poisonous agents. This is useful for remembering the assessment and management of different substances within the same group. 5 major toxidromes do exist today: narcotics, sympathomimetics, sedative hypnotics, cholinergics, anticholinergics. So, often a working diagnosis can be developed by looking at history and physical findings, vital signs to include ECG, SAT, and capnography. All right, so this is table 27-1. It lists the toxidrome. As you can see here, here's narcotics, sympathomimetic, sedative, hypnotic, cholinergic, and also anticholinergic. Gives you drugs examples, all of these guys here. This whole list. There we go. And the signs and symptoms. Okay. So there you go, 27-1. This is slide 16 of 186. Overview of substance abuse. Substance abuse often results in social stigmas in addition to finding physical effects. This is a wide variety growing problem of different types of substance in use today. The debate still exists regarding medicinal versus recreational use in some drugs. It's going back and forth, and I tell you, for example, marijuana has medicinal use and can be designed to limit a psychoactive component. So, the definition of substance abuse differs among cultures as well. So drug abuse, basic terms and concepts relate to substance abuse include drug abuse, which is any use of drugs that causes physical, psychological, economic, legal, or social harm to the users or to others affected by the user's behavior. Habitation is the psychological dependence on a drug or drugs. Right, so physical dependence, the definition of that is a physiological state of adaptation to a drug. It's usually characterized by a tolerance to the drug effects, and that the person gets a withdrawal syndrome if the drug is stopped. Psychological dependence is the emotional state of craving a drug to maintain a feeling of well-being. And then tolerance is the physical adaptation to the effects of a drug. Increasingly larger doses are required with these particular patients to achieve the same effect. Again, it's that chasing the dragon. They want to feel that same euphoria and that same high that they got the first time they ever used it, and that's going to be impossible. They'll never reach that. So the more they become physical dependent, the more they become tolerant to it, it gets them further away from that. All right, so withdrawal syndrome, it often occurs after the abrupt cessation of a decreased drug. This is an awful thing to watch people go through. Drug addiction is a chronic disorder characterized by the compulsive use of a substance. An antagonist is a drug with the affinity for a cell receptor. It really likes that particular cell receptor, and it goes to it on a constant basis. It is a molecule that blocks the ability of a given chemical to bind to its receptor, preventing that biological response. Potentiation is the enhancement or effect of one drug on another drug. Synergism is the action of two substances in which the total effects are greater than the sum of the independent effects. So, patient assessment. General assessment approach, is the same for all patients. Ensure good overall clinical picture of the patient has been established. If the patient is unresponsive, then obviously we're going to get in there and assess vital signs, make sure we do our ABCs, complete a rapid medical assessment, obtain a history from bystanders and family members. If the patient is responsive, we're going to use OPQRST, obtain our vital signs, get our sample history, perform a rapid scan, and then perform a more thorough physical exam. Now, patients with toxicological emergencies may also have sustained a traumatic event. Remember that the 2 and 2 could go in hand, especially in the industrial type of setting. All right, so scene size up. Obviously, safety is paramount with these kind of patients. Patients who have taken overdose may be very, very dangerous. Here's a different variety of things that you may see when you're out there. This obviously looks like a representation of crystal meth. Here, this is probably cocaine or crystal meth. This is a packaged version of one or the other, okay? Also, here's another packaged version of something, looks like marijuana, not real sure. And then, of course, lots of pills, and these are probably ecstasy. And then marijuana in this particular canister here. That's a crusher canister, so you can make it real fine and refined so you can roll it up, man. So, yeah, seen a lot of those. All right, so primary survey, obviously your general impression, identifying concerns of life threats. Identify whether this is a mechanism of injury or nature of illness or a combination of both, because it can be. Determine the severity and set the priorities. Where are we at on this and what's our transport decision? Basic airway management enables time to obtain whatever needed information we can get before we get going with this patient. All right, OPQRST, sample history, what was the substance or what is the substance? When was it ingested, injected, absorbed, or inhaled? Also ask how much was taken, what else was taken along with it, if anything, and has the patient vomited or aspirated, and why was the substance taken? Was the person wanting to do themselves in, or they want to get high? What's the deal? All right, so secondary assessment, toxicological emergency are often medical emergencies only. They might be able to be managed relatively easy. Patients may have alterations of mental status, or they may not. But a lot of them definitely have nausea and vomiting, especially your overdoses. For trauma, make sure that we're performing appropriate rapid trauma assessments and base whether the patient has a significant mechanism of injury. Reassessment, obviously reassessment is going back over and over again. What have we done for the patient? Is the airway still being managed properly? Is the circulation still on a positive side? And what are we doing here and where are we going and how quickly we're going to get there, and make sure that we give a report indicating what we've got to the receiving facility. All right, so emergency medical care, ensure scene safety, maintain the airway, ensure the breathing is adequate, ensure circulation is not compromised, and provide high concentration oxygen. These are all primaries. Establish IV access, administer whatever antidote if we have the possibility of doing that, and prepare to manage these patients that are in shock. They very well may be in shock because whatever it is, the medication may be causing massive amounts of vasodilation and therefore putting them into shock. Also watch out for coma, seizures, and also dysrhythmias, and get them to a hospital. They need treatment, okay? They absolutely need treatment. All right, so let's talk about some specifics. All right, so alcohol, it is the most widely abused drug in the United States. It's a part of our society. Most adults have drank alcohol or drunk alcohol, and almost 27% report binge drinking in the past month. Warning signs of alcoholism include consuming alcohol in large quantities for over a long period of time, spending considerable time obtaining alcohol, using alcohol, or recovering from its effect. Social or interpersonal problems due to the use of alcohol, reducing social occupation, or recreational activities due to alcohol use, and then continuing to use alcohol even after acknowledging the physical or physiological problems that are caused or exacerbated by the alcohol use. All right, so pathophysiology, psychological dependence on alcohol involves drinking to function normally and to feel good. Alcohol acts as definitely a depressant in the frontal lobe, and psychological and physical dependence can escalate very, very quickly. A person with alcoholism is more prone to have serious illnesses and injuries. Acute alcohol intoxication, you're going to do all this. You're going to manage their airways, suction available for sure because they're going to throw up more than likely. Provide supplemental oxygen and assist ventilation as necessary, and get you IV access. Monitor their EKG rhythm. Go ahead and get a blood glucose level. Administer thiamine if directed by a medical control, and then transport to an appropriate facility. Withdrawal seizures that occur between 12 to 48 hours of the last drink. Use the same care as for alcohol intoxication and consider administering benzodiazepines. Delirium tremens usually starts between 48 to 82 hours after the last drink, and these are your signs and symptoms, and they're pretty pretty straightforward on what they do and what's going to happen to your patient. You just try to manage these patients as best you can. Try to keep the patient calm, maintain personal safety, oxygen, establish vascular access, and maintain an ongoing dialogue with this patient. All right, so stimulants, they come in various forms. You can absorb them. You can absorption by ingestion, inhalation, or injection, either one. There are various forms. Most stimulants enhance the release of catecholamines, which stimulate the central nervous system. They can increase alertness and create a sense of euphoria. They can also lead to agitation, hypothermia, tachycardia, hypertension, and seizures. The visual picture of a patient who uses or abuses stimulants may include the following: agitation, anxiousness, delirium, any of these, difficulty sitting still, all these wonderful signs and symptoms here. All right, so cocaine, it is a stimulant. On the overview, it's a naturally occurring alkaloid that is extracted from erythrothyroxylon coca plant leaves found in South America. Once processed into cocaine hydrochloride, the active ingredient increases in its potency. It was historically used as an elixir for many different types of illnesses. Heck, at one time it was in Coca-Cola until the good folks at the newly formed Food and Drug Administration found out about that, and they created an act that makes, everybody knows what's in their drinks and their eats. So they eliminated that, from Coca-Cola in order to survive. Otherwise, they would have probably all been arrested. I wonder how much they imported to put in their Coca-Cola during that time and where they stored all that. Oh my God. Occasional use of a less pure solution will not create as much psychological or physiological dependence. Cocaine users with serious dependent problems may have significant health conditions as well as social and psychological challenges. Pathophysiology of this: cocaine is a local anesthetic and a nervous system stimulant. It enhances the release and activity of neurotransmitters in the body, to include norepinephrine, dopamine, and serotonin. Dopamine activity creates a euphoria that features enhanced alertness and a tremendous sense of well-being. Enhanced norepinephrine activity results in the stimulation of the sympathetic nervous system. This stimulation leads to common adverse effects such as tachycardia, hypertension, and hyperthermia. Every organ system is at risk due to the significant vasoconstriction, along with increased metabolic and oxygen demands from the cells. It is quickly absorbed across the mucosal membranes, allowing it to be applied topically, insufflated or snorted, swallowed, God, that's almost killed me, injected intravenously. And then crack cocaine. Crack cocaine is a cocaine mixed with baking soda and water that is either cooked or baked, and it's usually smoked. You don't hear a lot about crack anymore. That's kind of gone out of flavor there in the United States. I'll tell you what, it's alive and well in Brazil, in Rio. That's the big thing, man. That's what all the narco terrorists are holding everybody at bay over there with, is cocaine, crack cocaine. All right, so some of the pathophysiology of cocaine: absorption route determines the time and onset of the effects. It's usually 1 to 3 minutes when it's snorted, 8 to 10 seconds when it's smoked as crack. More frequent use and use of pure forms result in greater dependence and tolerance. When the effects wear off, the user experiences a crash, and that's usually characterized by depression, irritability, exhaustion, and possibly even washout and a hypoactive state due to the lack of neurotransmitters can occur as well. They may be difficult to assess. To avoid crashing, many users seek more cocaine or take a sedative like smoking pot or taking, a narcotic or that kind of thing, or a benzo. Heroin addicts claim cocaine provides relief from their withdrawal effects. I just don't get it, man. Why do people want to use this stuff? Yuck. Just what I want to do, right? I want to feel all anxious and withdrawal and freaked out and stuff. Why? All right, so assessment. Overdose may lead to chest pain, shortness of breath, diaphoresis, or psychosis. Cardiac effects also may be observed to be ventricular dysrhythmias, myocardial infarction, and also even sudden cardiac arrest. Amphetamines, methamphetamine, metylredoxamphetamine, and methyldioxy amphetamine, amphetamine. Oof, good Lord. Wow. Amphetamines include several different methylamphetamine, which is what they call crank or ice. Then you have methyldioxyamphetamine, which is MDA atom. Methyldioxymethamphetamine, which is MDA, Eve, ecstasy, that kind of stuff. Anyhow, all this crap offers an incredible high. It may be tainted with a lot of different additives. Some of the clinical applications of this stuff is nasal decongestants, diet pills, and drugs to treat narcolepsy, attention deficit disorder, and attention deficit hyperactivity disorder. Big time, there's an increased use of this stuff in schools. Pills for the attentional disorders may also be misused by the kids in school. Methamphetamine, it's a low cost, low acting, up to about 12 hours, long acting, up to about 12 hours. Ingredients are available very much so locally, and patient management is the same as for cocaine. Bath salts. Oh, here's another one that I don't really get. These are synthetic cathinones. They're called bath salts. They're psychoactive substances related to the chemical compound derived from the khat plant. Khat leaves are traditionally chewed for a stimulant and euphoric effect. Synthetic cathones are chemically engineered to have a higher potency. They offer effects similar to stimulants but usually cost a lot less. Sometimes sold as plant food or cleaners and labeled as not for human consumption. It says not for consumption. Why would you want to consume it? But people do. Do not confuse them with bathing products such as Epsom salts. Totally different. Not correct. They often have a white or brown crystal-like appearance and come in foil packages with names like Flocka, Cloud9, or White Lightning. They may be sold in convenience stores or gas stations, making them more accessible than any other illicit drugs. They can be ingested, insufflated, smoked, or injected. The speed of onset depends on the route of absorption. The two routes associated with the highest mortality rates are insufflation and needle injection. Use is associated with significant paranoia, hallucinations, incredible strength, excited delirium, and other bizarre behaviors. Also, tachycardia, diaphoresis, nausea, and hypothermia may be present in these patients as well. Management of stimulant abuse. You need to establish and maintain an airway, give supplemental oxygen, establish vascular access, and then apply the ECG monitor and also pulse oximeter. Administer benzodiazepines per protocol to calm them down, manage their hypotension with serofluid infusions. For violent behavior, follow local protocols, and also consider sedation on these kind of patients and transport them to the appropriate facility. Fluid resuscitation may be required for hypoperfusion, assess for cardiac dysrhythmias, treat chest pain as acute coronary syndrome. Local protocols may also allow for benzodiazepines for certain symptoms. Aggressive cooling may be indicated for hypothermia or signs of delirium or severe agitation. Throughout the resuscitation, maintain urine output with aggressive fluid therapy, and if the patient has a seizure, make sure we manage it pharmacologically. All right, so marijuana and cannabis compounds, they're derived from harvested dried cannabis and the cannabis sativa plant. Resin from flower tops can be used to produce hashish. Much controversy exists regarding The clinical use of marijuana, and obviously its legalization across the United States, it contains a number of cannabis compounds which may have different therapeutic effects, such as cannabidiol, which is CBD, one of the main active chemical compounds, may have significant therapeutic effects, including anti-seizure properties and neuroprotective properties, as well as analgesic properties and anti-tumor properties as well. CBD does not have euphoric effects or intoxicating effects of THC. It has served as the driving force for some states to enact laws to allow access to cannabidiol oil or high CBD strains of marijuana. Pathophysiology on this, bottom line is that it's a primary psychoactive ingredient is delta-9 tetrahydrocannabinol, or THC. THC binds to the cannabinoid receptors throughout the brain. Marijuana then may cause the user to have enhanced sensory perception and euphoria. These unusual effects may cause anxiety or panic as well. Common short-term effects of marijuana include tachycardia, balance coordination problems, and also increased appetite as well as conjunctival type of irritations. Now, conjunctival, speaking of injection, it causes a dryness of the conjunctivitis or of the tear ducts themselves. Also, dry mouth, possible memory loss, drowsiness and relaxation. Chronic use of marijuana may result in pulmonary symptoms without developing obstructed airway diseases, as seen with tobacco use. Smoking marijuana causes euphoria and relaxation primarily and alters the fine motor skills, concentration, and depth perception. Marijuana products may be ingested, insufflated, vaporized, and applied topically to the skin. Assessment and management of these patients. Intoxication and withdrawal from marijuana is not life-threatening. Novice users may become panicked or anxious due to the euphoria, spatial disorientation, and altered sense of reality that can occur. Emotional support and supportive care are often all that's required in these patients. Now, benzodiazepines may be considered for sedation if the patient is really freaking out or significantly anxious. If the patient has severe or life-threatening signs and symptoms, they can consider that another substance or drug may be at work and may have been unaware that the stuff was in it, so you just never know. Pediatric patients experience more serious signs and symptoms after ingestion of an edible food source that has been adulterated with marijuana, such as lollipops, brownies, or gummy bears. Need to contact poison control and provide prompt transport to the hospital, as the child will likely require hospitalization. Spice, a synthetic cannabinoid that falls into the category of a new psychoactive substances. It's often marketed as synthetic marijuana. However, the active substance is a blend of chemicals that is either sprayed onto a plant-like material for smoking or sold as a liquid for vaporizing in electronic cigarettes. Some users report euphoria similar to marijuana use. These chemicals can be much more dangerous than marijuana. The adverse effects of spike use include psychosis, hallucinations, tachycardia, vomiting, renal conditions, seizures, and various chemicals may have been used in the spice development. So the patient presentations may vary. You just never know. Supportive care with fluids and antiemetics is often, appropriate and about all you need to do. If the patient is experiencing a seizure, then benzodiazepines are the medication of choice. All right, so hallucinogens, they cause some kind of distorted sense of perception, period. They may also create a realistic sensation of images or sounds that are not actually present. Experiences with hallucinogens are unpredictable and can vary markedly from one person to another. The drug experience is affected by the user's previous drug experience, the dose taken, and the social setting in which they took it in. It's classified into two categories: synthetic, which includes LSD, PCP, ketamine. Naturally occurring hallucinogens can include mescaline, psilocybin mushrooms, and then seeds of the Jimson weed plant. All right, so lysergic acid, diethylamine acid, readily available, easy to make. It's made from rye. It's derived from the fungus of the contaminants of rye flour and wheat. It is usually ingested orally and sold on the street in tablets, caplets, or liquid form. The onset is generally 30 to 60 minutes. The duration of the effect can last up to 24 hours. Pathophysiology, LSD has the ability to distort reality, change a person's mood, or alter perceptions and or reality. LSD may also result in the user experiencing a synthesis or a crossing of the senses. Because the potency of LSD, even small doses, may create a significant experience for the first-time user, you just never know how these people are going to react. Higher doses may lead to a longer duration and more intense experience. Tolerances can develop, but almost no evidence exists of a physical dependence or withdrawal syndrome if the user stops using the drugs. The effects are mostly sympathomimetic, often consisting of mild tachycardia, palpitations, mydriasis, and sweating. Now, the following will occur in a bad trip. The user has vivid, frightening experience similar to a nightmare, resulting in acute anxiety attack and the physical effects secondary to increased anxiety. The bad trip does not end until the drug wears off. Woohoo, let's just go do some LSD, right? Assessment and management treatment is primarily supportive. You got to let it run its course. There's not a whole lot you can do. You can treat these patients. You can consider anxiolytics for patients with severe anxiety, but that's about it. All right, phencyclidine. It's a dissociative anesthetic with hallucinogenic properties, otherwise known as PCP. This, also called angel dust or rocket fuel, it hasn't been around for a long time. I just don't hear any cases of PCP overdoses. It's just not one of those things anymore. The pathophysiology of the stuff, it's a dissociative anesthetic that has hallucinogenic properties. It was developed in the 1950s as an IV anesthetic, but is no longer used for any medical purposes in the United States. It is commonly sold in a powder, crystal, or tablet form. Sometimes it's used to dip marijuana cigarettes in them. It's commonly added to other illicit drugs to create a more intense high. Pathophysiology, PCP works on the N-methyl D-aspartate, the NMDA receptors. PCP has the ability to distort sight and sound and make the user feel separated from his or her own body. It is typically smoked or snorted, but it also can be injected. Small doses, even 5 to 10 milligrams, can produce signs and symptoms of intoxication. A high from a single dose can last up to 4 to 6 hours. Common signs include slurred speech, staggered gait, tachycardia, hypertension, staring blankly for extended periods of time, and horizontal nystagmus, muscle rigidity, and grinding of the teeth. Users may also display extraordinary strength and have a sense of invincibility or seem to lack awareness of pain, continuing to function despite significant orthopedic injuries. Assessment and management, personal safety, administer high flow oxygen, monitor vital signs, and provide safe transport. Mostly supportive. And if you absolutely had to, you could use large doses of benzodiazepines, try to calm them down a little bit, but that's found to be proven to be pretty ineffective in these kind of overdoses. But like I said, it's just not around anymore. It's not one of those drugs that the users like to abuse anymore. Ketamine, whole different story. Ketamine, also known in the illicit world as Special K or vitamin K. It's a dissociative anesthetic. It's relatively short acting and has clinical uses, obviously, in the veterinary and also in our medical fields. Our pre-hospital indications is pain control or management of aggressive patients. Sometimes it's added to other more illicit drugs to produce a more intense experience for the user. Its pathophysiology, it works on an NMDA receptor sites. It also binds to mu-opioid receptors, giving it analgesic properties as well. At low doses, a user presents with a little bit of mild inebriation, euphoria, increased sociability, and then at higher doses, the users may have pronounced nausea, difficulty moving, significant hallucinations, and maybe even coma. Assessment management, hey, you got to secure the patient well, assess and manage their ABCs, provide oxygen therapy, establish vascular access, and provide safe transport. All right, peyote and mescaline, pathophysiology on this. It's used by native tribes in the southwestern United States and also in Mexico for thousands of years. Its pathophysiology is really kind of unknown. The exact mechanism of action has not been determined. The dried flower or buttons may be ingested or soaked in water to produce a liquid infused with mescaline. It's a psychedelic experience that begins with feelings of increased sensitivity to sensory and stimulation, flashes of color, a distortion of time and space, and then some have reported even out-of-body experiences. Hallucinations that are influenced by an environment are definitely a big part of it as well. Physical effects, it may include dilated pupils, increased pulse rate, mild hypertension, and increased in body temperature. All right, so the assessment management pre-hospital care is really just supportive, supplemental oxygen, monitor vital signs, provide psychological support for if they're freaking out, and then arrange for safe transport to a hospital so they can be monitored. All right, psilocybin mushrooms. Don't want to eat these guys. All right, so they contain hallucinogenic substances, which is called psilocybin and also psilocin. Their most commonly abused mushrooms are Psilocybe mexicana and also Psilocybe cyanesis. The typical dose is estimated to be somewhere between 4 to 10 milligrams, or approximately 2 to 4 mushrooms. Typically, it's got a bitter taste, which may be masked with other liquids or foods. The pathophysiology behind this guy is the onset symptoms and hallucinogenic effects are usually within about 30 minutes of ingestion. It lasts for a while, about 4 to 6 hours. Signs and symptoms include muscle weakness, drowsiness, nausea, vomiting, mydriasis, mild tachycardia, mild hypertension. The likelihood of any serious medical side effects, it's very, very low. Assessment management, ABCs, monitor the vital signs, safely transport, establish vascular access, and give some fluid if need be. Let's kind of thin them out a little bit. Sedatives and hypnotics. Sedative and hypnotics have a wide range of uses. They function primarily as our CNS depressants. The sedative are used to reduce anxiety and calm agitation, and hypnotics are used as sleeping aids. They definitely have a high potential for abuse. Barbiturates, there are really, they act as a CNS depressant. There were established therapeutic uses as anxiolytics or anti-anxiety meds, anticonvulsants, and also hypnotics. Clinically, they're similar to alcohol in terms of dependence and withdrawal symptoms. Combined with alcohol for suicide is definitely something that has been used in the past. Its pathophysiology, barbiturates potentiate gamma-aminobutyric acid, or GABA, at their specific receptors to inhibit cellular excitation. There are 4 different configurations. Ultra short acting, which are highly lipid soluble, rapid onset, short acting, immediate acting, and long acting. Long acting definitely is less lipid soluble than the ultra short acting. Delay onset, long duration of action. You just, these can hang around for quite some time or for a short time. It all depends on which one it is. Right, assessment, mild to moderate barbiturate intoxication, like I said, is much like alcohol. As the dose increases, they become more lethargic, so you may have to support their airway, especially if they're mixing alcohol with barbiturates as well. Management, airway control, always the first priority, with any patient. Monitor oxygenation and ventilation with the use of oximetry and also capnography. If shock develops, crystalloids may be needed. For long-acting barbiturates, administer sodium bicarbonate to alkalize the urine. Folks, you got to remember this: barbiturates, sodium bicarb. Okay, so amitriptyline, sodium bicarb. Okay, to alkalize the urine, so you'll save this person's life. Abrupt cessation in a long-term abuser produces withdrawal syndromes in approximately 24 hours. Rapid transport is indicated for these types of patients. All right, benzodiazepines. They're members of the sedative hypnotic family. They're common to use to treat anxiety, seizures, and withdrawal symptoms. Their pathophysiology, they exert effects by stimulating the GABA pathways, and they result in sedation and reduced anxiety. IV route's the most preferred route for pre-hospital. Assessment: single entity overdose has really a low morbidity rate, not a big deal. Do need to watch out for them, make sure you manage their airways. So the common clinical effects are, altered mentation, drowsiness, slurred speech, and also general incoordination. All right, management: airway, oxygen, vascular access, ECG monitor, pulse ox, and capnographer. And you can also use flumazenil. Flumazenil is the reversing agent for benzodiazepines. Good stuff, but you got to be careful. If they're already currently on benzodiazepines, for instance, for seizure activity, and you slam them with flumazenil, they may start having seizures on. So be very careful. Make sure you have a good history before you start using flumazenil as your reverser. Make sure they don't have a common use for benzos. Narcotics, opiates, and opioids. Okay, they're CNS depressants. They produce an insensibility and also stupor complex, and they manage your pain very well. They are classified into the following: opiates, which are various alkaloids derived from the opium or poppy plant. And then opioids, which are synthetic narcotics with sedative properties that are not derived from opium. In recent years, incredibly potent drugs such as carfentanil and desomorphine have increased in the use on the streets. Pre-hospital providers have seen a significant increase in the number of opioid overdoses since 2000. The risk of addiction or abuse should not influence your decision on to treat acute pain in the pre-hospital environment. This is what they're derived for. This is what they're supposed to be for, is to manage people's pain. Don't withhold it. All right, pathophysiology: they bind with receptor sites in the brain and tissues. They produce analgesia and also euphoria. And the effects are lessened when taken orally primarily. The best way to do is to inject them. Dose of naloxone may not permanently reverse the effects of heroin, but at least it gets rid of it in the short term so that you can manage patient's airway. All right, assessment. These are classic presentations here, and it produces a dreamlike state for the patients. Management: airway. Give them naloxone as necessary. If the patient does not respond to naloxone, they may have taken something else or something a little bit more potent synthetic drug. So keep that in mind. All right, so here's your opioid-associated life-threatening emergency adult algorithm that was developed in 2015. You can keep this in your little toolbox. Cardiac medications. Okay, so can produce severe effects on the body when they reach toxic levels. Major classes of cardiac drugs include these guys right here: antidysrhythmics, beta blockers, calcium channel blockers, cardiac glycosides, and also angiotensin converting enzyme inhibitors. Overdoses of this stuff can create some really detrimental effects to people. Assessment: use the patient's history and list of meds to help identify the substances. Minimize negative effects while determining the antidote. Contact poison control or meta control early. Sodium channel blocker toxicity. You need to look for this stuff. Overdoses can cause any of these problems. So, watch out for them. You may have to be prepared to deal with them as necessary. Beta-adrenergic type of problems, typically they present with the following: hypotension, bradycardia, related symptoms such as all this good stuff here, lethargy, weakness, hypoglycemia, especially in pediatric patients, and then bronchospasms in patients that have some kind of reactive airway disease. Consider atropine sulfate for symptomatic bradycardia, but it may be useful only in mild overdoses. Consider fluid boluses for hypertension. IV glucagon is the antidote to beta-adrenergic blocker toxicity. Administer 1 milligram of it, IV glucagon, every 5 minutes. If the patient may not respond until at least 6 milligrams have been given, it's a lot. The ED may administer a glucagon infusion after the bolus has been initiated. Potassium channel blocker toxicity, it may present as hypotension, bradycardia, and also certain ventricular dysrhythmias. One of the predominant effects observed is on the ECG is a prolonged QT interval. So treatment of acute potassium channel blocker toxicity is primarily supportive, although you may use IV magnesium sulfate to treat torsades de Pointes if it shows up. Calcium channel blocker toxicity, it may be present with the following: decreased pulse rate, AV nodal conduction, decreased myocardial contractility, vasodilation, nausea and vomiting, altered mental status, and metabolic acidosis. So, IV calcium chloride or calcium gluconate is the initial treatment. Do not miss this. That is out there. It's in several different algorithms and testing stations for different tests that you may have to take in the future. IV glucagon may improve both pulse rate and myocardial contractility. Standard crystalloid infusions of 20 cc's per kilogram may assist with their hypertension. And then recommended vasopressors after fluid resuscitation include norepinephrine and dopamine. Cardiac glycosides, such as digoxin, they're particularly problematic to maintain within a therapeutic range. Acute dig toxicity presents with nausea, vomiting, and GI distress, and also lethal hyperkalemia. So digoxin immune, fab or Digivine is the definitive treatment of acute digoxin toxicity, but it's likely to be unavailable in the pre-hospital environment. So supportive care and consideration of calcium gluconate may be reasonable. Because of the sophistication of cardiac drugs, the likelihood of polypharmacy of these kind of patients is very, very possible. So you need to contact medical control on how to manage them. All right, organophosphates. It's a major component in most insecticides. They include acephate, diazinon, methylathion, carbamates, and also nerve agents. These common exposures, they usually come by accidental, but suicide's possible. Usually it's by ingestion. They drink this stuff and they don't survive. But accidental is folks that have a tractor overturned, or they get into spillage and they don't know it's there. You get a kid that's running around out in the yard after it's been sprayed, but usually it's accidental. Pathophysiology: the dumbbells, mnemonic, diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, and seizures. Also, you have sludge as well: salivation, lacrimation, urination, defecation, and emesis. So this one, dumbbells, is a little bit more extensive. Sludge works also as well. So whichever you choose. In moderate to severe organophosphate poisonings, you see muscle fasciculation, severe respiratory distress, seizures, and also flaccid paralysis as well. Assessment management. Man, you got to decontaminate these people. They're going to be covered in this stuff, or at least have it on a part where you don't want to get mixed up in it. So establish and maintain their airway, establish vascular access, and administer atropine. High doses of atropine is indicated. You can go beyond the 3 milligram dose. So definitely think about it. And also perlidoxamine, also infused with normal saline, will work as well. Assessment, apply, monitor, immediate transport for these kind of patients. Carbon monoxide. Fatal exposures are often associated with gas-powered heaters in confined spaces, running vehicles in a closed garage, and house fires. I think everybody knows the pathophysiology of this is colorless, odorless, tasteless. It displaces oxygen, preventing oxygenation to the tissues because it's binding on the red blood cells. These are your assessments. These are the different things that you're going to find with these kind of patients. It's more pronounced in your conscious patient that's been exposed to, some period of time that, say, they're working on a vehicle or working on a small engine in a closed space. Not very brilliant. But anyhow, this is signs and symptoms you'll see. Management, hey, highest concentration of oxygen. Remove the patient from the environment. Get the airway established in high flow oxygen. Keep the patient quiet and rest, monitor ECG rhythm, and transport them to an appropriate facility. Chlorine gas, yuck, but oxygen is what counteracts this stuff. Chlorine compounds are commonly used at home and also in the occupational setting. Household ingestion can occur due to solutions kept in unlabeled containers, and acute exposures are in industry occur due to faulty valves or pumps, those kind of things. Pathophysiology, minor exposure may include burning sensation of the eyes, nose, and throat, and a slight cough. Severe exposure may be cyanosis, shock, and seizures. Could be bad stuff. Assessment management, remove all patients from the area and triage high concentration oxygen. Takes care of it, no problem. I have personal experience with that. I was exposed to chlorine when I was young. I was a baseball player and went into the bathroom, and everything was green. I just didn't understand it. Well, the bathroom was connected to the pool. There was a chlorine leak, and that's why all the metal fixtures were green. And yeah, within about 15 to 20 minutes, I couldn't breathe. Oxygen cleared it right up. Cyanide, gaseous form, hydrogen cyanide, often colorless and bitter, kind of almond scent. Rapid acting and a deadly poison. It combines with the cytochrome oxidase, which blocks the utilization of oxygen at a cellular type of level. It's found in many household goods, believe it or not, absolutely. It can be found in a lot of different types of household stuff. It can also be used in the manufacturing of plastic, paper, and textiles. The process also of electroplating also has it. Some plants and seeds have it, including the peach seed. Cyanide poisoning has been used as a method of execution, genocide, and suicide. It's one of the most rapid acting and deadly poisons out there. It's considered a mitochondrial toxin. It combines with a crucial cellular enzyme, which is the cytochrome oxidase, which blocks the utilization of oxygen at the cellular level, which ultimately results in cellular suffocation and also death within seconds. Death within minutes if it was, or possibly an hour or two if ingested, but in seconds if it's inhaled. This is your assessment. These are some of the things that you may find. They're very, very common to other types of inhaled poisons. several different inhaled poisons mimic the same. Management 100% oxygen, and the goal is to displace cyanide from the cytochrome by introducing another chemical to bind it is the primary. But if you will definitely begin with high oxygen flow, that will help right off in the immediate. Amyl nitrate kit is the primary treatment if available. If not available, hold gauze soaked in amyl nitrate over the patient's nose. Anticipate hypotension and keep the patient supine with the legs elevated. If the systolic blood pressure falls below 80, consult medical control about whether to administer an IV vasopressor. And of course, monitor the rhythm carefully, ECG rhythm, notify the receiving hospital of a problem diagnosis so their staff can begin a preparation of sodium thiosulfate. Transport without delay to the appropriate facility. All right, so hydroxycobalamin, it is a member of the vitamin B12 family. It can be considered, if available, for patients who are hypertensive, have altered mental status, or in cardiac arrest after being removed from a house fire. Hydroxycobalamin may skew laboratory findings, so obtain a blood sample before administering the drug. It is a safe alternative or adjunct to the traditional treatment of cyanide poisoning. Patients may experience side effects of redness of the skin, eyes, and urine, and also itching. Methylene blue, that's another alternative. It's used to treat methylmobile, which may occur during the treatment of cyanide poisoning with sodium nitrate. Methylglobulinemia is the alteration of the structure of the hemoglobin, induced by the administration of amyl nitrate and also sodium nitrate. It should be avoided in mild cases of cyanide poisoning. It's typically administered under the guidance of an expert. It's not something that is just, yeah, we're going to use methylene blue to correct this or to reverse this. No, no, no. This is done in the hospital over a long period of time. All right, so caustics. Here you go. Substance, example, and sources, acids and alkalis, table 27-5. Lots of industry out there use both of these items. And so you can see here under sources, under both on what all is an alkali and what's an acid out there. Pathophysiology, hey, it causes chemical injuries to tissue, signs and symptoms, drooling, burns, and difficulty talking. As you can see, here's different applications for different caustics. Assessment management for ingestion, dilute milk, water within minutes of exposure. Establish vascular access, immediate transport. For dermal exposure, dilute and flush away the substance. The solution to pollution is dilution. Okay. Eye exposure, place the prong section of a nasal cannula on the bridge of the patient's nose and flush copiously. Just connect it up to a macro IV set and flush it with normal saline. Keep it running all the way to the hospital. Do not give any neutralizing substances. Don't induce vomiting. Don't perform gastric lavage, but you can give activated charcoal if it's part of your protocol. Common household items, hey, dangerous items in the household may include colorful plants, cleaning products, all kinds of interesting stuff. Identification of the substances involved is the most important part, is the history of, how they got into it, where this plant is, and what type of plant it is. I mean, like, for instance, the angel trumpet has atropine and belladonna. It has killed children many, many times over because it's pretty. It's a beautiful flower, but it can be very, very deadly. Same thing with a Brazilian pepper tree. Brazilian pepper tree makes wonderful honey. It's just phenomenally flavorful, but it is poisonous. I mean, if you eat the berries, it's a very caustic kind of berry and can cause really bad burns, and some people are allergic to it. Drugs that increase sexual gratification. Obviously, we have those out there for erectile dysfunction and other things that use for gratification. Erectile dysfunction is the primary. They're phosphodiesterase type 5s, PDESs, such as sildenafil, tadalafil, and also vardenafil. They're the most common. Unintentional toxic levels are usually a result of aggressive dosing to achieve maximum sexual performance. Elevated levels may produce hypotension, tachycardia, ischemic chest pain, tachydysrhythmias, and also prolonged priapism, requiring a urological evaluation. Supportive care is usually all we can do for these kind of patients. Cocaine and other stimulant drugs, they administer serial boluses and oral saline to try to flush out that. Amyl nitrate has also been used for sexual gratification. It can be crushed up and inhaled. Hypotension usually can result from any of this from the blood pooling in the periphery, owing it to the drug's vasodilatory effects. So they may be hypotensive. And then, of course, ecstasy, which creates an incredible sense of well-being. Treatments, as discussed previously, for stimulant abuse. Dextromethorphan, that's unusual, but it's cough medicine, several over-the-counter cough suppressants. For a while, kids were drinking this stuff. I mean, they would just down a whole bottle of Robitussin. It can produce a euphoric, floating kind of sensation. It's a mild stimulant effect, also with approximately only 6 tablets. Large quantity consumption can cause hallucinations and psychedelic visions, as well as loss of motor control, confusion, and blurred vision. It also causes like a dream-like kind of euphoria, which produces out-of-body type of sensations. It's interesting. Yeah, I remember for a long time, kids were getting into that. We had several overdoses come to the emergency department of cough medicine. All right, so date rape drugs, they're specifically out there for sexual assault. such as GHB gamma hydrobutyric, rohypnol, an indigenous metabolite of gamma aminobutyric acid. It causes intoxication similar to alcohol. Then neuromodulators involved with sleep cycles, memory retention, and also emotional control. It is odorless and it's colorless, and it's primarily a liquid that may go undetected when placed in a drink. It exerts its effects within about 60 minutes. Ingestion may produce disinhibition, severe passivity, also antegrade amnesia. With alcohol, there's an increased risk of respiratory depression, coma, death, and then even withdrawal presentation. And it's very similar to alcohol or benzodiazepine use. GHB continued, establish, supportive care, maintain the airway. There's nothing that's going to reverse it. Supplemental oxygen, make sure to look at their monitor, provide rapid transport to the hospital. If there's any question at all that the person may have been raped or any suspicion of that, make sure you're preserving evidence as well. And if you can by chance get, the glass or whatever it is that they ingested, and take that with you. That'll be good for analysis and maybe even for a court case. So, all right, rohypnol, specifically known as roofies, it is a very potent benzodiazepine. It has profound effects when combined with another drug that works to depress the CNS. You can cause unconsciousness, respiratory depression, and even death. It's illegal to make or distribute, period. There's nothing legal about it. There's no use for it at this point in time. So, just not a good thing. All right, methyl alcohol, formaldehyde, formic acid are responsible for methanol poisonings. Alcohols manufactured for industrial or non-gastronomic purposes are not good to be consuming, such as methyl alcohol, which is wood alcohol or methanol. It is present in paints, paint remover, windshield washer fluid, varnishes, antifreeze, and canned fuels. Methanol itself is not harmful. It's breakdown products, formaldehyde and formic acid, that are responsible for methanol poisonings. A dose of 60 to 250 mLs in adults or 8 to 10 mLs in children is associated with severe toxicology or toxicity. Pathophysiology of this, peak blood levels are attained within about 90 minutes. Mild toxicity is the half-life up to about 14 to 20 hours. It increases to 24 to 30 hours in severe cases. Assessment, they appear in about 12 to 18 hours. This is all stuff that goes along with it, kind of similar to many other ingested substances. Nausea, vomiting, headache, vertigo, abdominal pain, maybe even blurred vision or blindness. Physical exams, altered mental status, dilated pupils with sluggish, no reaction to capnia, and also hypotensive. Management, airway. Consider blood glucose levels. You can also consider sodium bicarbonate on these patients. You need to establish IV access, get their glucose level. Activated charcoal is often contraindicated unless other substances were ingested as well. Consult medical control for as far as sodium bicarb. Morbidity and mortality are often driven by the amount that was ingested and the speed at which the patient receives definitive treatment. So, provide immediate transport as quickly as possible to the hospital. Ethylene glycol is a colorless, odorless liquid. It's found in a variety of commercial products to include antifreeze, coolant, and de-icers, and also polishes and paints. It is similar to methanol and often is ingested in the absence of ethanol. Estimated lethal dose is about 2 milliliters per kilogram, or as little as 150 milliliters. Pathophysiology of this, ethylene glycol is water soluble. It's absorbed rapidly when taken orally. Peak blood levels are usually within 4 hours. The liver and the kidneys metabolize it into a number of toxic metabolites. It runs just a storm of crap through your body, such as aldehydes, lactate, oxalate, glycolate as well. These metabolites produce metabolic acidosis, and it's just a freight train to disaster on that. So not good. All right, so assessment stage 1, soon after ingestion, toxicity begins. ingestion about 12 hours. CNS depression, intoxicated appearance. Notably, there's an absence of odor or ethanol in the breath. There is none. Nausea and vomiting, seizures, or coma will begin. Stage 2, somewhere between 12 and 24 hours after the ingestion, start getting cardiopulmonary symptoms. Hypertension or even hypotension or tachycardia can occur. Pulmonary injury may be present as pulmonary edema or pneumonitis or acute respiratory distress syndrome. Patient may have hypocalcemia due to the calcium oxalate precipitation. Stage 3, 24 to 72 hours after ingestion. Flank pain, anuria, and hematuria often occur. Acute renal failure may start to develop, and a patient is on the downhill slide of dying. Management care is the same as for methanol poisoning. Not a whole lot you can do. The exception, you may be ordered by medical control to administer 10 milliliters of 10% calcium gluconate IV to slow IV to push to treat the patient, the hypocalcemia. So once at the hospital care, they focus on correction of the acidosis and the administration of fomepizole or ethanol, and then renal dialysis. All right, so hydrocarbons. Hydrocarbons, carbons made up of only hydrogen and carbon. They're found in a variety of products at home, including natural gas, cleaning agents, petroleum distillates, also fluorocarbons, and also hydrocarbon inhalation. Products containing hydrocarbons are widely available. Inhalation is often the route of exposure for users without access or to funds to purchase illicit drugs. 3 common methods include huffing, sniffing, and bagging. So this is the guy that can't afford to go out and buy drugs, so he steals paint out of the stores. He shoves them in his pants or his coat or whatever, and goes outside and sprays it in a bag and smells it, snorts it, and huffs it. And then you walk up to him to treat him and say, "Have you been huffing?" And he says, "No, I haven't been huffing." He looks up at you and his whole face is gold. It's from the gold paint. Yeah, right. You haven't been huffing, all right. So high abuse potential. It's for those that seek that cheap buzz kind of thing. And like I said, a lot of folks, they go out and they steal it and then use it. Treatment, remove the patient from whatever that crap is and administer high concentrated oxygen, and get the patient some help. Get them to a facility. All right, so here's some list of halogenated hydrocarbons and also petroleum hydrocarbons. This is 27-6, 124 slide. Hydrocarbon ingestion, the pathophysiology on this, the lower the viscosity of the agent, the higher risk of aspiration and other complications will be. Low viscosity hydrocarbons can easily enter the lungs during swallowing. Low viscosity facilitates the uptake of hydrocarbon by the tissues of the central nervous system and its anesthetic effects. It shows an initial experience of excitement and euphoria for your patient, followed by a loss of fine motor skills, drowsiness, confusion, and coma. You can even have cardiac dysrhythmias present with this, so monitoring their ECG is going to be very, very important. Many products cause gastric irritation as well. Just a single exposure may cause sudden death. You just never know. So, not a good thing. Assessment management, obviously ensure proper decontamination, airway, oxygen, vascular access, monitor. There's really not much more that you can do for these folks. So that's about it. All right, hydrofluoric acid and hydrogen fluoride, nasty stuff. Hydrofluoric acid is hydrogen fluoride that has been placed into an aqueous solution. It can cause devastating local and systemic toxicity from exposure to an extremely small amount. It is primarily used in industrial settings. What it does, it leaches calcium and magnesium from body tissues, and ultimately it results in profound hypocalcemia and hypomagnesemia. It's also a massive release of sequestered potassium into the systemic circulation as well. So bad stuff, really bad stuff. Um, Obviously, with all these, shifts of the different electrolytes, you're going to get a lot of weird stuff, dysrhythmias, tumor, seizures, CNS depression, and then acidemia as well. Inhalation causes, ingestion causes, these are all different things that you may see for both. Take a look at those on your own. Management, ABCs for ingestion, provide stomach evacuation. And you can also consider if the patient starts showing real signs and symptoms, you can work with them for ingestion. Consider dilution with milk and water. Also, calcium gluconate may also be used. A paste of water-soluble lubricant and also 10% calcium gluconate may be applied to any local burns. IV administration of 10% sodium gluconate also may be allowed by local protocols or online medical control in the presence of cardiac irritability. Hydrogen sulfide. Hydrogen sulfide is a highly toxic colorless gas with a distinctive smell of rotten egg odor. Its poisonings usually occurs by inhalation. Its effects are throughout all organs, but it's mostly impacting the lungs and the central nervous system. Chronic exposure may cause patients to lose their ability to smell the gas. Low-level exposures, you'll get this, Very high levels of exposures could cause much more serious seizures, shock, coma, and also even cardiopulmonary arrest. Assessment management, there's no proven antidote. Remove the patient from the contaminated area, give them high flow oxygen, and get them to the hospital. Oxides of nitrogen, which also include nitric oxides, and also nitrogen dioxide. These gases form a byproduct of fuel combustion. Nitric oxide is a colorless or brownish at room temperature with a sweet smell. Nitrogen dioxide is colorless or brownless with a very harsh odor. Exposures may come from kerosene heaters in the home or from facilities that produce nitric acid. So, pathophysiology. The exposure can result in irritation of the throat, upper respiratory tract, also pulmonary edema, and also difficulty breathing and weakness. Assessment management, get them out of there. There's nothing you can do to give them any antidotes or anything. But the thing is that they're going to get, weaker and weaker, and they're going to get harder and harder to breathe. So be prepared to intubate these patients. Tricyclic antidepressants. This does happen. Folks do overdose on these, and these particular medications, they're still out there in one form or another. So you need to understand the tricyclic antidepressants, or the TCAs. They're designed to alter dysfunctions of mood and affect thought, orientation, and or perception. Antidepressants accounted for over 75,000 adult exposures and were the fourth most common pharmaceutical involved in fatal exposures in 2014. Ingestion may have been intentional, and polypharmacy also may have been present as well. Tricycline antidepressants, they were frequently prescribed for depression in the past and are now used for insomnia, eating disorders, and also personality disorders. Common TCAs are just these guys here: your amitriptyline, doxepin, nortriptyline, trimipramine, and clomipramine as well. So, an assessment of these patients. Patients may present with any of these particular problems. The anti-mucoric qualities may produce signs and symptoms similar to the anticholinergic toxidromes. Hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. The patient will exhibit hypothermia, dilated pupils, dry skin, and mucous membranes, also reddened skin, and agitation or delirium. Be alert for ECG changes in these kind of patients. This is a very significant thing. Prolonged PR intervals, tachycardias, widening QRSs. Also, terminal R waves greater than 3 millimeters at AVR or in AVR. Prolonged QT interval specifically can be also a problem. Altered mental status and delirium and seizures is also possible. Toxic ingestion of TCAs. A patient who presents with serious signs and symptoms within 6 hours of ingestion should be considered critical. Management, airway, obviously, very, very important. High flow oxygen, for SATs, to achieve SATs greater than 94. Vascular access, ECG, administer activated charcoal per medical control orders. Consult with med control and consider sodium bicarbonate administration. Management of hypotension with subsequent boluses of normal saline. Assess blood glucose levels. It's very, very important. Rule out head trauma and also be alert for agitation and violence. Do not give flumazenil or phytocytogenine. Okay. Treat seizures with benzodiazepines as appropriate. Provide rapid transport to the appropriate facility. Monoxamine oxidase inhibitors, MAOIs. MAOIs are primarily used to treat atypical depression. Norepinephrine, serotonin, and dopamine are the primary neurotransmitters that assist with improving mood and affect. What monoamine oxidases do, or MAOs, it's an enzyme that removes these neurotransmitters from the brain. MAOIs prevent the regular removal of the neurotransmitters. At toxic levels, they can block these enzymes for a short or long duration based on the medication. Assessment, these are all your signs and symptoms. They are often delayed up to about 6 or 12 hours following the ingestion, but you can see all these things in those types of overdoses. Effects are severe of toxicity include all of these: hypothermia, rigidity, respiratory failure, and delirium, seizures. Prepare to manage these patients from life threat because they may go into cardiac arrest very, very easily. No antidotes available for overdose, period. So maintain and establish an airway. High flow, large bore IV, monitor their ECG rhythm. Consider activated charcoal. Treat hypertension with normal saline. If seizures occur, you can treat them with benzos. If the patient's hyperthermic, consider metalazine to calm them down a bit and, maybe bring their temperature down a little bit. And that's all because their body's freaking out. So, selective serotonin reuptake inhibitors. Okay, a little bit on the other side. They have a larger therapeutic window. They enhance serotogenic neurotransmission and inhibit the breakdown of serotonin. They have a few cardiac effects or anticholinergic effects, so they are a safer option for depression compared to TCAs. They include fluoxetine, which is Prozac, paroxetine, which is Paxil, and citalopram, which is Celexa, and sertraline, which is Zoloft. These are all very popular medicines. Combinations thereof are definitely stuff that people take. Assessment, half these patients are usually asymptomatic, about 50% of them, so yeah, with an overdose. When taken with alcohol, look for tachycardia, mild hypertension, and lethargy. Other common symptoms are what you see here for sure. Okay. Management, airway, high flow oxygen, vascular access, and monitor their ECG. Consider activated charcoal and also benzodiazepines as necessary. If they're having seizures, if a widening of the QRS occurs, consult with medical control for consideration of sodium bicarb administration. Transport to the appropriate facility for treatment. Serotonin syndrome, it can occur with drugs. It's an idiosyncratic complication that occasionally occurs with antidepressant therapy. It can occur with any combination of drugs that increases the central serotonin neurotransmission. Drugs that can cause serotonin syndrome include MAOIs, SSRIs, and TCAs, as well as lithium stimulants and opioids as well. The presentations are, widely different in severity and may be complicated by consideration of single or multiple substance toxicity versus serotonin syndrome. The onset of serotonin syndrome is commonly within 6 hours of ingestion. Signs and symptoms include all of these guys right here: delirium, tachycardia, hypertension, and also diaphoresis and diarrhea. Our pre-hospital treatment is nothing more than, supportive. Lithium, it's a common mood stimulator, but there's so many other types of mood stabilizers out there. Treatment of bipolar disorders. Not very many people are on lithium anymore. There's so many other choices out there. It assists with the dampening of the mood swings rather than affecting the normal mood. Pathophysiology is almost completely absorbed in the GI tract at about, after 8 hours after ingestion. Approximately 1/3 remains in their blood system for about 2 weeks, so it hangs around for a while. High risk of toxic levels and overdose with this particular drug because it does stay in the body for such a long period of time. Assessment, here you go: nausea, vomiting, hand tremors, excessive thirst, and as it increases, you'll see all this kind of stuff. So, not a good one, no doubt about it. Management: airway, vascular access, ECG, non-prescription pain medications, non-steroidal anti-inflammatories, NSAIDs, rapidly absorbed, half-lives varied all over the place, and most problems involved in these particular problems are from long-term. Assessment, many overdoses are asymptomatic. At toxic levels, the signs and symptoms at most could be nausea, vomiting, and some abdominal cramping. Management, same way. Vascular access, O2, normal saline, benzos, if they have seizures, and get them to an appropriate facility to manage it. Salicylates, acid, taking aspirin, clinical presentation can change based on age, the dose, and the duration. Overdose in children is usually accidental. In adults, it's usually intentional. Airway, administer normal saline for hypertension, monitor carbon dioxide levels, administer activated charcoal if instructed, and transport to a facility. Acetaminophen, it's well tolerated with very few side effects overall. This is your different stages of toxicity and what can happen. So let's prove a table here, table 27-7. Here's your assessment and management. Just with any medication, you need to establish what time that it was taken and how much was taken. And the antidote of this is acetylcysteine, and that'll be administered in the hospital. We don't carry that stuff in the field. Get them to a hospital. Lead, okay, result from environmental contamination. Inorganic lead, actually excreted from the body, is very, very slow. And then organic lead is tetraethyl lead. It's usually found in paint and that kind of stuff. And we really don't have a whole lot of that in patients who do ingest lead. They're very vague and non-specific symptoms that go along with it. There you go, 27-8, symptoms affected by lead poisoning. Iron, toxic effects in large amount of ingestion. You need to get around 20 to 60 milligrams per kilogram. It's severe and potentially lethal toxicity once you get up to around 60. Only a small amount is required as a part of our healthy diet. So many multivitamins contain iron. So kids get a hold of the Flintstones and chew the hell out of that and end up getting a lot of iron in their body. And it's just not good for them, no doubt about it. Excessive amounts of iron in the body can speed up the formation of oxygen-free radicals, creating metabolic acidosis. Assessment management: iron poisoning, we usually call symptoms about 6 hours. You'll see vomiting, diarrhea, and abdominal pain. Later stages: shock, seizures, hypothermia, liver failure. ABCs and transports are primary. Mercury, yeah, you might see this in an industrial plant. Toxic effects from all forms of mercury. It's lipid soluble and quickly accumulates in the liver, CNS, and also the kidneys. It can cross placental membranes into the fetus as well. Your assessment depends on the type of mercury, the route of entry. Involves usually your CNS, your GI, and your renal systems. Management: remove the patient from the source, obviously, pay basic attention to the ABCs, and transport them to a facility. Arsenic can enter its body through ingestion, inhalation, absorption, and also through the skin. It's involved in approximately 8% of heavy metal poisonings. Used in many industries, so often source of unintentional exposures happen. Pathophysiology can enter the body through those what we just talked about. It's eliminated through the kidneys, but it tears up stuff all the way home. So, yeah. There's your assessment. Clinical presentation depends on the type, the amount, concentration, and the rate of absorption and elimination. Symptoms appear within 30 minutes to several hours, and it can consider all of these as symptoms that you may see. Management, hypertension management, normal saline, consider mag sulfate for any torsades that shows up and get them to an appropriate facility. Poisonous plants, there are only a few plants that are actually poisonous. Approximately 65% of the exposures, involve children aged 5 years and younger. Deaths are rare, and ingestion usually results in minimal symptoms. Now, there's a few different ones that we can talk about. Dieffenbachia, which is a green plant with broad vegetative leaves. You can see here, all parts of the plant contain sharp calcium oxalate crystals. When ingested, these crystals cause burns in the mouth and also the tongue, paralysis of vocal cords, edema of the tongue, and also larynx, leading to airway compromise. Cladidium, it's multicolored leaves. You can see here, same results as the Dieffenbachia. Azaleas and rhododendrons that can cause cholinergic type of symptoms. Lantanas, red sage or wild sage. Lansatine A is also within the berries. It can cause some poisonings. Pretty flowers though. Castor bean. Chewing on these guys, especially foods, can kill a child. This is not a good thing because chewing them is going to get the ricin out of it, which is the poison in the castor beans. And it causes a variety of toxic effects to include the burning of the mouth and throat, nausea, vomiting, diarrhea, severe stomach pains, prostration, failing vision. Kidney failure is the big one. So, I mean, at the end of the day, your child may die because they're chewing on seeds. Not a good thing. All right, so foxglove contains cardiac glycosides. It's what digitalis is made from. Beautiful plant, very, very pretty. Poisonous plants continue. I'll get all the information you can. What plant was ingested? How much did they eat? Did they boil it down to a tea? Or, how did they adjust it? Kind of things will be very, very important. Management, most exposures require no treatment. Contact the Poison Control Center. A child symptomatic should be evaluated at the emergency department, plain and simple. Poisonous mushrooms, factors determine toxic results. The age of the mushroom, the season it was gathered, the amount was ingested. It's hard to tell the difference between a good mushroom and a bad mushroom if you don't know. Would you know by looking at these two different mushrooms which one's good and which one's bad? No, not unless you go and pick them all the time. I know morels. Morels are very pretty and they're very easy to find in special places, and they are yummy. They're little tall, skinny little dudes. They're kind of like your finger. They look a lot like a finger, and they got a little cap on the top. They're little bunches, little groups. Good stuff. You can buy those in the store. Yum. All right, so assessment, time and symptom can be served as a predictor of potential severity. Most commonly see cramping, diarrhea, vomiting, and GI bleeding. Airway, vascular access is the big thing. Normal saline for hypertension and contact poison control. Food poisoning. When you encounter, two or more people sick at the same time and at the same scene with similar symptoms, think food poisoning or CO poisoning. You may be asked to evaluate patients concerned after being notified of a food recall. Pathophysiology of this, 3 toxins are frequently associated with food-related deaths: Salmonella, Listeria, and Toxoplasma. Poisoning with Clostridium botulinum is usually the result of improper food storage or canning. Toxins produced by dinoflagellates in red tods may contaminate bivalve shellfish. Cooking does not kill these types of toxins. So assessment, onset signs and symptoms can range between several hours, days, or weeks. Gastrointestinal complaints are the most common. Respiratory distress or arrest can occur, but it's just not frequent and rare, very rare. All right, so establishment, management, establish the airway, establish vascular access, administer normal saline, consider diphenhydramine for any facial flushing to make them a bit more comfortable, maybe even a sedative if they're upset, and an antiemetic like Zofran to help them out if they're nauseated. All right, folks, guess what? That was 1 hour and 33 minutes. That is the end of this chapter. Thanks for bearing with me. This was a long one. Toxicology, there's a lot more stuff, and we just scratched the surface of it. There's some really great publications on toxicology and the ins and outs of managing these types of patients. So be sure to look it up on the internet. There's some good stuff out there. With that, I'll bid you adieu. Thank you very much for watching, and we will see you next time. Have a good one. Be sure to clock out and take your Quizlet.